Hello, everyone, and welcome to this Hoosier Extracorporeal Science Conference and NRP series brought to you by Heartbeat Perfusion Solutions. Today, I'm joined by Dr. Ahmed, who is an associate professor of surgery, specializing in cardiothoracic surgery with expertise including coronary artery bypass grafting, valve surgery, transplants, and devices like LVADs and ECMO. Dr. Ahmed has published 61 peer-reviewed articles, co-authored textbook chapters, and regularly presents at international medical conferences. Thank you so much for being here, Dr. Ahmed.
Thank you, Sam, for having me on. It's my pleasure to be here today.
We look forward to learning from you. For today's presentation, it will start with Dr. Ahmed giving a short presentation on his work, and then I'll come back on and ask some of the key questions that we're often asked about NRP and this industry. And the key objectives for today is really to explore NRP's advantages as well as the evolution of the procedure, patient outcomes and organ viability, as well as what the barriers are to integrating this type of procedure into existing transplant programs. If you're not familiar, this webinar series is brought to us all by Heartbeat Perfusion Solutions. They are a national provider of specialized perfusion and extracorporeal membrane oxygenation services, ECMO. They offer critical support for cardiac surgeries and patients requiring advanced life support, working alongside hospitals and surgical teams to ensure optimal patient outcomes. Their services include expert staffing, equipment, and management for both short-term and long-term perfusion and ECMO needs. So on that note, I'll pass things over to you, Dr. Ahmed. You can start with your presentation.
Hello, everyone. It's my pleasure to be here today, and thank you, everyone, for coming on and attending this presentation. So today, I'm going to talk about normothermic regional perfusion, specifically about the thoracoabdominal normothermic regional perfusion today. I'm going to start first with definition and concept, just to give a background for everyone to be aware the terms we use and abbreviations. So the first one is what's called donation after brain death, DVD. As all of you know that most of our donors are brain death donors, and usually we diagnose brain death by certain criteria like cessation of brain stem function, cessation of reflexes, positive apnea test, absent brain blood flow. The second category of our donors is DCD, which is donation after circulatory death. In the past, that term was used as or was called donation after cardiac death, which was not really the right scientific term. Later, it became donation after circulatory death because number one, the heart is not dead. Number two, it is really about the circulation, it's not about the cardiac activity. Also, the techniques of recovering DCD heart, currently we have two techniques of recovering DCD heart. Number one, what's called DPP, or direct procurement perfusion, which is as you know, we open very fast and then we perfuse the heart with cold cardiovascular solution, and then we take the heart out and use the ex vivo heart perfusion machine. The second technique, which is the normothermic regional perfusion, which is unlike the other one, this is in situ or in vivo, inside the body, perfusing the organ with warm oxygenated blood. We have two different NRPs, the thoracoabdominal NRP or abdominal NRP. And then the second point, which is important also in the discussion in the field, what's called ante-mortem cannulation or post-mortem cannulation. As you know, it is mainly post-mortem cannulation. However, with the evolution of the field and the demand for better quality of the organs, an increasing number of centers now are adopting what's called the antemortem cannulation. So with getting a special consent to cannulate before cardiac arrest. Then again, we have central versus femoral cannulation. Central either abdominal or thoracic, and the femoral cannulation, it is femoral cannulation from the groin. And again, femoral cannulation either to do cut down or percutaneous. It is important for us, thoracic surgeons. Me personally, my experience about femoral cannulation, it is always for us cut down, not percutaneous. Percutaneous is maybe it works for abdominal surgeons. However, for thoracic surgeons, it is cut down because it saves time for us, because you have to open the chest pharynx, clamp the arch branches, and then reestablish or establish the bypass from the femoral vessels. So you don't have time to use a percutaneous technique. So you need to cannula in after cut down and connect it to the line, and you just open after you open the chest and the clamp the arch branches, and then you can establish the bypass. Here is a historical background. As we see two pictures, the one on the left, I'm sure most of you guys are familiar with this person. This is Dr. Kirsten Bernard, the famous surgeon who performed the first heart transplant ever in history. That was in December 3rd, 1967 in Cape Town, South Africa. And the one on the left, Neil Armstrong landing on the moon for the first time, that was July 16, 1969. The reason I put these two pictures, because number one, when Dr. Bernard performed the first heart transplant at that time, that was equivalent actually to landing on the moon. That was a magnificent progress in the field of medicine, and that's why I put the two pictures together. The second reason I put Dr. Kirsten Bernard picture is not only because he did the first heart transplant, but just to remind all of you guys that when Dr. Bernard performed heart transplant, or the first heart transplant, he did actually series of heart transplants, and all of them, they were DCD donors. There was no definition of brain death at that time, because brain death was defined later by Harvard Medical School. That was in 1968. So just to know that Dr. Bernard performed all the heart transplants using DCD donors. So it is amazing to just to think about it. The DCD donor, that was the original heart transplant procedure, and then DBD donor, and then back to DCD donor again. So we can say something all became new, but even better. Here, this one, the timeline of NRP. I'm gonna just take you through the steps of the procedure. So we start first with withdrawal of the life support therapy, and then we will mark what's called the functional warm ischemia time, which is a criteria when the systolic pressure is 50 or less. Once we get the systolic pressure 50, this is the point we start the time of the warm ischemia time. And then after the functional warm ischemia time, then we get to the cardiac arrest. And then after cardiac arrest, we have what's called the no touch period or the standoff period, which is averagely 5 minutes. It is about 3 to 5 minutes, based on the policy of the hospital or policy of the center. And then after the 5 minutes, the surgical procedure starts. And until you get to the reperfusing the heart, it takes averagely, most of the centers, they do it between 5 to 10 minutes. And this is actually the start of the NRP. In NRP, we stay on bypass. Is averagely 45 minutes. Some centers they go 60 minutes. And then after that will be a regular recovery like any other DVD donor. This slide shows the metabolic changes happen during the warm ischemia time. As you see, this is the pre-ischemia time. And then once we start what's called the hypoxia because of the lack of oxygen, then a lot of metabolic changes happen. The free fatty acids, lactate, catecholamines, this increase, and this will lead to a drop in the pH and acidosis and rise of glucose level. With more hypoxic condition, then the body will, the body cells will start having different electrolyte balance or passing the electrolyte across the cell membrane, and that because mainly of drop of the ATP, which is the energy required for the sodium potassium pump across the cell membrane. This slide shows the same time frame or sequences like before, like the previous slide. However, this slide shows the kind of team duty. So between the surgeons above here and then the anesthesia team. So the surgery team will take care of incisions and cannulation, going at bypass. However, at the same time, you have the anesthesia team taking care of re-intubation, performing bronchoscopy to the patient, connecting venous lines, starting drips, starting fluids and everything required for the procedure, monitoring blood pressure, and optimizing the mean arterial pressure during the whole procedure. This slide, by the way, shows it is more technical slide because there are a lot of talks about collaterals during the NRP or reperfusion of the brain. Because as you know, we clamp the 3 arch branches. This is a nominate, the left concarotid, left subclavian. However, theoretically, if you clamp all the arch branches, anatomically, there's some collaterals still can bring some blood into the brain circulation, even if you clamp the 3 arch branches. However, there is more than one study measured this amount of blood going to the brain, and they investigated if this amount of blood will have any impact on the viability of the brain cells, and they concluded that the amount of blood reaches the brain through the collaterals during the NRP is too small, is too little to have any impact on the viability of the brain cells. Now I'm going to talk about how we prepare as a team to start the NRP. This is my own checklist I prepared for my institution. So this checklist is formed of 14 points. And this checklist is important for us because we ask our procurement coordinator to go over all these points when she receives like an offer, and we accept the offer, and then she goes over these points with the donor center to make sure we have everything available for the procedure. It's like if you have anesthesia available, anesthesia team available, if we have a sternal saw, if we have sternal tractor, if we have vascular clamps, if we have if the withdrawal of life support will be in the OR or outside the OR, if we have backed RBCs ready for the procedure, and then the next one, if there is antemortem cannulation or not, based on the hospital policy, and then if we can do a huddle phone call before leaving our hospital, so all the teams will get together on a huddle phone call to make sure all of us we are on the same page and everyone knows exactly what we are going to do, and we have kind of agreement about what we are going to do. I feel like this 14-point checklist sheet is very helpful for us not to miss any of these items before we start the procedure. This one also shows, you know, sometimes we get the heart, sometimes we get the lung, sometimes we get the heart and lung, sometimes we do NRP, sometimes we do OCS or ex vivo perfusion. So again, this one also will help the team to understand which procedure we were going to get these items. So this one, you bought this one as well, so to make it easier for everyone to be aware of what we need. This is the like an example of the bypass machine we use, and all of you, as you are familiar with that, this is just one model. However, different centers, they have their own different model and different setup. But however, this is like a standard one. So the advantage of this one that it fits well, so we can put them in boxes and then we assemble them in the OR. So we will have kind of space in the van on the plane, so it can fit well, unlike the regular heart lung machine we use in the OR, which is too big to fit in the plane and the van. Now we're going to talk about the outcome after thoracoabdominal NRP. I'm going to these are the most recent publications in the literature about outcome for the heart and outcome for the lungs. As you know, there is a lot of debate, ongoing debate about the recovering lungs in NRP or after NRP. And so that's why I 3 or 4 reports about the heart and 3 reports about the lung. So for this one, this is one from the Vanderbilt group, and this is the biggest actually series of thoracoabdominal NRP. They are the busiest center in the country doing NRP. So in this article, they published about 100 cases of NRP, heart recovery through thoracoabdominal NRP, and they compared the outcome of heart recovery from NRP versus regular DBD. They compared them in terms of 1-year survival, BGD, and they concluded that there is no any significant statistical difference between the 2 groups for heart recovery through NRP versus regular DBD. This is a second study. This is a wider study, a bigger study. This is international study, including also Vanderbilt and other different countries. And you can see here from Spain, from UK, and from Belgium and United States. In this study, they published about 157 cases of thoracoabdominal NRP in which the heart was recovered. And again, they compared the survival at 1 year and 5 years, comparing the heart recovery from NRP versus regular DBD. And again, they found no significant statistical difference between the 2 groups in terms of survival and 1 and 5 years. This is another series from New York group, and here they published about 18 cases of NRP, heart recovery through the thoracoabdominal NRP, And again, they compare them for survival, and the same, they didn't find any statistical difference between the two groups after they concluded the procedure. This is the another study. This study assessed the echocardiographic metrics of the LV and the RV. They compared the metrics before recovery and then after recovery, and they found that most of the cases they did the study on, the LV and the RV almost recover the same echocardiographic metrics before and after NRP. This is the a group of Cedars-Sinai in Los Angeles publishing their lung series. In this one, they use the UNIS database to look at the outcome of lungs recovered through the thoracoabdominal NRP, and they found and they compared that for the BGD, primary graft dysfunction, and for requirements for ECMO or ventilation support post-op. They found that for lungs recovered and implanted after thoracoabdominal RP, comparing that to the regular DCD recovery, there is no statistical difference between the two groups after transplantation. This is another group, Johns Hopkins. They reported here using the using NRP to recover lungs, and also they did this one as a national study. About 17 lungs were recovered and transplanted through the thoracoabdominal NRP, and they compared the survival at 30 days, 60 days, and 90 days post-transplant. And again, the results were matching with the regular DCD recovery. This is another group from Colorado, and in this study, they published about 8 lungs recovered through the thoracoabdominal NRP. And again, they looked at the survival as well. And again, the survival between the two groups, between lungs recovered through the thoracoabdominal NRP and regular DCD recovery, there was no statistical significant difference between the two groups after transplant. Thank you.
Well done. Thank you. Do you need a sip of water before we go into the Q&A? I know that can sometimes be a lot.
No, fine. Yeah, absolutely.
Okay, well, I have a few questions for you to just follow up on what you've just shared with us. So when we think about NRP in the field of organ transplantation, how has it evolved? And what advantages does it offer when we think about more traditional methods and previous methods that were available?
You know, Sam, it's very interesting that I mentioned something about Christian Bernard, the first heart transplant back in 1967. It's very interesting that to know the procedure he himself used to recover the heart, the first heart ever, was something similar to NRP. But the only difference, it was not normothermic, it was hypothermic. So he did the same technique actually we do for NRP, but he didn't keep the temperature at normal temperature. No, he cooled down the temperature, and then he recovered the heart, and then there was abdominal surgeon recovered lungs and liver as well. So it is really amazing to go back NRP to the first heart transplant ever. And then after that, after we start, doing the DCD again, that was almost late 2019, then now we start using the NRP, but using normothermic. Normothermic means that the temperature is normal. We don't cool the body and keep the normal temperature. So with time, it is getting popular. And the good thing about NRP, for many of us know that it has number one advantage of cost. It really dropped the cost of the procedure. Number two, which is very technical, if you compare that to ex vivo perfusion, that in vivo or inside the body will allow us to see the heart fully functioning, because outside the body, the heart is contracting but not fully functioning. But inside the body, the heart is contracting and fully loaded and functioning. So we will have a better chance, better way to look at the heart and to assess the myocardial function better than ex vivo. Other factor too, let's say we do a case like we recover the heart, and then the liver team or the kidney team, they want to do NRP for abdominal organ. So we will do together thoraco-abdominal. So it will be one procedure for the all organs. That's why we call it thoraco-abdominal NRP.
Okay, thank you. When we're thinking about the outcomes, though, so it's helpful to hear like how the procedure actually compares and how it's differed. But what about in terms of the results that we're getting? What are some of the typical outcomes for patients that receive organs via NRP compared to a patient who would receive an organ via a more traditional method? What do we know?
Yes. As you saw on the slide I presented actually the most recent publication from all over the world, including the United States experience and the international experience. And all the publications or reports I presented here, they reported that the outcome is matching with the regular DBD donation. So it's like you're comparing DCD using thoraco-abdominal NRP to a regular donation after brain death. So no statistical difference between the two groups in terms of survival, in terms of BGD, requirements for mechanical support post-op or any like ventilation support in ICU. However, which is very important, if there is no any statistical difference between the two groups, however, the advantage here that the NRP enables the center to increase the number of transplants. Some centers increase the number by 30%, some centers increase by 40%. Just imagine if a center is doing like 100 heart transplants a year, and then if they adopt the NRP next year, you are talking about 30 or maybe 40 hearts extra, yet with the same outcome like a regular DBD.
Okay, that sounds very promising.
Yeah. Yeah.
What about the ischemia time of organs? How critical of a factor is this in improving organ viability?
Yes. If you remember one of the slides, I showed the metabolic changes. This happened with the ongoing hypoxemia. Hypoxemia means lack of oxygen. Once the body starts suffering lack of oxygen, then we will have something called the metabolic changes happen. Release of some metabolites, which is related to hypoxemia, increase fatty acids, increase glucose, and acidosis, drop the pH. And then if the ischemia continues, then this will lead to cell injury and potentially cell death. So the big advantage for NRP, once we get what's called the warm ischemia time, and this is happens when the systolic blood pressure is 50, and we start measuring it until we start perfusing the organs with warm oxygenated blood. The NRP averagely from skin incision until we establish the bypass flow Most of the centers, it takes between 5 to 10 minutes. So it is very important to cut the warm ischemia time as fast as possible to save the viability of the cells and hence the viability of the organ. So that's why actually there was a study published by Mayo Clinic Jacksonville liver transplant group about the warm ischemia time, and they concluded that from skin incision until you get to the organ, if it is less than 5 minutes, this is after the 5-minute standoff. So it is total 10 minutes. If you add standoff period 5 minutes and then cutting the skin until you get the organ and perfuse the organ, so you have 10 minutes. So they concluded that if you perfuse the organ under 10 minutes, there is a statistical difference between the outcome under 10 minutes or above 10 minutes. So it's very critical to cut the warm ischemia time short below 10 minutes.
Okay, that's a good thing to note. Thank you.
Yeah.
What about the key clinical indicators for choosing NRP in a given case? What would those be?
Well, the indication of the procedure itself, I would say there are general indications. However, it's still institutional preference sometimes. Let's say age of the donor. We prefer the age of the donor to be not too old, like less than 45, because it is you remember it is a DCD case. It is a warm ischemia time. So it is better to have a little bit younger donor, so the heart can tolerate ischemia much better than, we don't go really above 50. Number two, as I said, if there is an abdominal team and the abdominal team would like to recover the heart and liver using NRP, so there's another indication, disadvantage for NRP, to do NRP for heart, lung, liver, and all the organs. Also, as I said, indication also the cost, the drop saving the budget. Some centers, they do not have enough budget to, for example, to use the ex vivo perfusion. So here the budget is really low. So the centers can increase their number of transplants with at a reasonable budget. Yeah, so also, you know, sometimes like I would say for NRP, if really you need to see the heart, if you want to really see something, if you are nervous or panic about the quality of the organ, so you put the heart on function and you evaluate the heart and you will see it, and you do FaceTime with the implant surgeon, and everybody will be on the same page, and the decision will be much easier to accept the heart. So there will be a kind of more comfort to accept the heart after NRP.
Okay, my final question for you, I know we're almost at time.
Yeah.
When we think about integrating NRP into the broader transplant program ecosystem, what are potential barriers to achieving widespread adoption of this? What should we try to get ahead of and think of when we're trying to really adopt this procedure on a more global scale?
That's a very good question, by the way. And actually, it's a key question for the whole thing, because we have two different factors here. Factors related to the center themselves and factors related to the authorities overseeing the procedure itself. I mean, UNIS and the OPOs, which is Organ Procurement Organization. So at the moment, there are a lot of ongoing debates about the NRP from the legal point of view, from the ethical point of view. And as I showed in my slides, there are different techniques to do what's called antemortem cannulation, postmortem cannulation, because these issues will really make a difference in the outcome. Because antemortem cannulation, if you cannulate it before cardiac arrest, this will really shorten the ischemia time even more. So if you talk about the OPO, Dionys, I think there is a ethical committee of the American Society of Transplant Surgeons put a kind of guidelines how we run the procedure, and it is very important as guidelines for every center, every surgeon to follow. Number two, for the centers, it needs a well-trained team. This is not like any other surgery. It is a very sensitive time constraint, so you need to do the procedure as fast as possible. So I believe if we have a specialized teams, specialized doing NRP, this is going to be a huge step for improving the outcome.
Well, thank you so much, Dr. Ahmed, for your time today. And thank you for everybody who has tuned in. If you're not familiar with Heartbeat Perfusion Solutions, you can visit their website and learn more about their services. And Dr. Ahmed is one of 5 amazing speakers that we've curated for this science conference and online series. So you can visit our YouTube channel to see the past discussions, and you're now on our email list to hear about the next 2. So until next time, thank you so much, everybody, and we hope you enjoyed
Thank you,
this.
Sam. Thank you so much.